Hello and welcome to the Evidence-Based Urgent Care Urgentology Podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this program from EB Medicine, the Evidence-Based Urgentology Podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Welcome, everyone, to the podcast for the May issue of Evidence-Based Urgent Care. Here with Tracy, we're going to talk about urgent care management of migraine and other primary headaches. We have some promos this month. Our first is Safeguarding Charting Document Support That Will Stand Up in Court. I think your smiling face is on the front of this.
There it is. Yeah, this was my brainchild.
Very cool. 4 CME credits go along with this, and you can find it at www.ebmedicine.net/safeguarding-charting. There is a new and improved version, hard to believe that it can be approved upon, but a new and improved version of the laceration course. You can find it at www.ebmedicine.net/store, and you'll actually see all of the things, all of the additional CME publications and other things. I think safeguarding charting is accessible there too. So look for the new laceration course there.
Yeah, laceration course. Super cool. There's some really cool animated videos in there, that actually, even though it's an animation, it looks like somebody's suturing and
really high quality,
really good updates. Yep. And yeah, really good stuff in there.
It makes it really easy to see too where the needle should go. And it's a really great job. And the final promotion for the month is site-wide. It is a free downloadable antibiotics guide available for free with any subscription if you just use the code MAYAPG.
So today we're going to talk about the urgent care management of migraines and primary headaches. And our authors on this issue were Griffin Shimp, DO, who's in the Department of Emergency Medicine at Hershey Penn State Medical Center in Hershey, Pennsylvania. Where else would that be?
Mm-hmm.
And Robert Olympia, MD, who's a professor of the Department of Emergency Medicine and Pediatrics. Also Penn State College of Medicine, which is also at Hershey Penn State Medical Center in Hershey, Pennsylvania.
Our peer reviewer this month is Joseph Wong. He is actually a certified medical lab scientist, as well as having an MPH, and he's also a physician assistant. He works at the Aproxy Urgent Care in Madison, Alabama. He is also lab director at Urgent Care of Oconee in Athens, Georgia, and he is adjunct faculty instructor at Mercer University, as well as South College in Atlanta, Georgia.
Awesome. So this time we're going to try a new format, see how you guys like it a little bit. We were kind of getting tired of just reading the issue and hitting the high points. Now we're just going to be a little more conversational about it. We picked out maybe 10 or 15 high points of the article, and we're just going to give it a whirl and have a little bit of discussion about it. I hope you guys like it. Please give us feedback and let us know what you think. We're going to talk about all those things that are don't miss and common pitfalls. And the real goal is to try and be less boring. If you want a lot of background and charts and all the esoterica that goes along with this, please read the article. There's a lot of really juicy, meaty stuff in there that we're not going to touch on. But like I said, if you're interested, just go ahead and read that article.
Read the article.
I know, hard to say.
So first thing in evaluating a headache, Tracy, I think you'll agree, is to exclude more serious causes of a headache. There's some red flags we need to watch out for. Once we move past that, you can either establish a diagnosis or treat a headache that's already been diagnosed. There's some structure to this, but I'd have to say, and I know you're going to talk about it a little bit more in depth, the things that I like to think about or ask about, you have to cover these in your history with any headache patient is this the worst headache of your life or a sudden severe onset? If you have a patient who suffers with headaches regularly, is this headache different than usual in some important way? Any kind of ongoing and progressively worsening headache is usually going to be something that you're going to have to work up a little bit more than just treating the patient with an analgesic. Associated symptoms also important, I think, for me, and on most of these kind of clinical decision rules that we use. Are there any neuro symptoms or exam deficits that we find? Any visual changes that you can't really convince yourself are migrainous? A lot of patients complain of blurry vision, and of course, migraine patients will have kind of typical visual symptoms, but anything that's out of the ordinary. Any kind of non-migrainous nausea or vomiting that's associated with a headache. Fever, of course. Headache can accompany a lot of infectious illnesses, but in this case, you're really more interested in what the cause of the fever is rather than the headache. So you got to work that up. And I would say rarely you might find your migraine patient where an infection is a trigger for their migraine, but people usually don't have kind of two causes for their headache. So fever, worry more about the fever than the headache. Many of these criteria and others are covered in that SNOOP 10 mnemonic that I think you're going to cover further. There's also a clinical decision rule that I like to use for subarachnoid hemorrhage, the Ottawa rule, that I think you're going to talk about. And all those are important in kind of formulating your differential and excluding those more serious causes of headache. What's your approach?
Yeah, I mean, for everything that I approach, including headaches, chest pain, all these things that are potentially life-threatening, is I have a list of red flags in my head, and if they come up with those red flags, that's going to make me think long and hard about, can I treat this patient here? Or is this somebody that's going to need a little bit more workup that I'm going to have to send to somewhere else? Oddly enough, I had 3 people this week that complained of the worst headache of their life. And of course, the medical assistant wrote it in the chart as the chief complaint. Like, really, now I have to really go and address this and sort of say to the patient, really, is this really the worst headache of your life? And why is it the worst headache of your life? 2 of them were like, well, yeah, I mean, I haven't had one this bad in a long time. It's the same as my usual. It just maybe lasted a little longer, or, I ran out of my drugs, so it got out of control. Really wasn't the worst headache of their life. But always be suspicious when they say that. I also bring in urgent care that a lot of people will walk up to the desk and tell that to the secretary because they think it's somehow going to get them in faster. So be wary about that one. But if they do say it and someone, God forbid, documents it in the medical record, you need to make sure that you explain that this is not the worst headache of their life because, or this is what they meant when they said that. So always make sure you're really careful when you document that. But there's a few other things like it occurred during exertion that I always get worried about. The thunderclap thing, like I was just sitting there minding my own business when I felt like a thunderbolt went through my head, and now I have a severe headache. And then any neurologic deficit that goes along with it, that's different than what they usually experience with migraine. One of our friends in the Urgent Care Association used to have ocular migraines all the time. And we used to always think, oh my God, poor man's having a stroke. He's like, no, it's just my migraine. I'm not having a stroke. Don't you worry about it. So, you got to know, or the people have to know, or they have to tell you, or the family has to tell you what their usual headache syndrome is. And is this similar? And once they say, oh yeah, this is my usual, you're usually golden on that one.
Always reassured. Yep.
Yeah.
Same thing happening over and over again.
Yeah. Just a word about migraines. A lot of people who have no medical training, patients, think that migraine is synonymous for the word headache. And they'll say that I have migraine, but they really don't have what we educated in the medical profession know what a migraine is. They may say that, well, I always have migraines. So, well, have you ever been seen a doctor? No. Have you ever been worked up? No. Did anybody ever label you with that? No. Are you on any medicine for it? No. So, okay, they're probably not really having migraines. This is probably something that we're going to have to ask a little more about. If they answer yes to all of those questions and they've seen a neurologist and they've had the workup, then you can kind of breathe the sigh of relief and say, okay, I'm good. I can go down the migraine pathway and just treat them for migraines and not have to think a little bit more about it. So don't always take the patient at face value at their word if they're telling you that they're having a migraine, because it may just be a headache. And I found that a lot of people also really have tension headaches and they've labeled themselves as migraines. So you really kind of have to do your due diligence and ask about that, see what their previous workup was, their previous testing was, their previous treatments were, things that have worked for them in the past. I always like to say to patients, I don't like to reinvent the wheel. If it's worked for you before, I'm just going to use it again. And that's always a helpful thing to kind of steer you in the right direction and how you're going to work them up and treat them.
I'll usually tell people I have my favorite combination of medicines I like to use for whatever headache in general, but is there one that works for you? And that way it doesn't seem like you're just asking them what they want.
Right.
And you know yourself better than anybody else. And I think a lot of times patients know.
Right.
Yeah. In terms of primary headaches, we always like to have diagnostic tests for things, right? You have a positive test result and then you're like, oh, this is what you have. Even then you have to be careful. But with primary headaches like migraine and tension, it's all based on just the description. There's the International Classification of Headache Disorders. It's now in its 3rd version. And it's kind of like the DSM-5, like psychiatric illness. There's no blood test or scan you can do. It's really based on the patient's description. I think most of us are familiar with these things. Migraines tend to be hemicranial, throbbing. There's associated photophobia, nausea with or without vomiting. And it turns out that a patient has to have a specific number of those things for it really to be diagnosed as a migraine, according to that ICHD, the third edition there. In that, tension headaches are defined as well. They tend to be frontal, occipital, and they can be severe, even though people think migraines maybe are a little bit worse. People can have severe tension headaches. Rather than being throbbing, the description of the pain is usually more tense or pressure-like, and there's no associated visual symptoms, nausea or vomiting. But like you said, sometimes people just put a different label on it. And I would say sometimes it sounds like patients have migraines. They might not have all the criteria. And similar to what we say with other things, sometimes an atypical presentation of a common thing is more common than an uncommon thing. And if the patient's had that headache over and over again, but it doesn't exactly fit, it can be reassuring in terms of your approach and not worrying about something worse. I think the toughest thing about this is diagnosing that first migraine when a person comes in with a severe headache and they're vomiting and they haven't been diagnosed before and they can't tell you that the headache is similar to a prior one.
I can't think of I've ever really seen somebody that's never had a headache before, but yeah, I mean, it is kind of maybe kids or something like that. Or, and then I'll ask, like, if it's a teenager, did your mother have these? Oh, yeah, she had them just like this. I'm like, oh, okay, that makes a little more sense.
Yeah.
Yeah, it's kind of interesting. And these are diagnoses of exclusion too. I mean, there's no way to prove somebody has a migraine or prove someone has a tension headache. You got to rule out all the other stuff that you can prove first. So who do we have to image? Do we have to image anybody in urgent care? Well, no. If they've had a previous migraine and this is the same as their migraine, there's no reason why we have to image them unless they have any of those red flags, symptoms that we were thinking of. But like what you were saying, what if it is the patient's first migraine or they haven't been worked up in the past before? You may be very suspicious it's migraine, but like I said, it's a diagnosis of exclusion. You need to rule it out and do some other things. Not everybody that has their first headache that is not previously diagnosed, we don't have to send them all to the ED and work them up. They can get their workup with their CT and their MR or whatever else that they may need as an outpatient. Unless they have any of those red flag symptoms, you really don't need to worry about shuffling them off to the ED for that imaging just because it's their first headache or you're not sure that they don't have a previous diagnosis of migraines that's been worked up in the past. So especially if they have a PCP or they have someone that they can follow up with and you think they're a really good candidate for follow-up as an outpatient, you don't have to get them imaged as an emergency. You can get it done in a couple of weeks if you have to. Like I said, though, some people that have any of those red flag symptoms, they should definitely be imaged. If they have a fever, thunderclap headache, occurred during exertion, different than their usual headache, any sort of neurologic symptoms that may be new for them, all of those you should make sure you image. And just a word about age. Age greater than 50, really unusual for people to develop migraines at that age. So if that's a new thing for them after age 50, they need to work up to make sure that there's not anything else going on. Probably a little more sooner rather than later, but not necessarily as an emergency if you can treat them and make them a little more comfortable before you send them out and they're not unstable in any way, shape, or form. So that's good. We didn't talk about peripheral headaches. Should we mention that?
Yeah, maybe. Migraines are miserable, but these might be worse.
Yeah, right.
And luckily, they're the least common, I think, of the primary headaches. It seems like in practice, and the issue mentions that. But they can be pretty troublesome. These headaches are, like the name says, clustered. So there's a regular occurrence daily or so, sometimes even several times a day. The headaches can last for minutes or hours. Occasionally, you'll see somebody with cluster headaches who then goes into a status situation where there's the cluster off and on, and then they have a continuous headache. And those people are just miserable. The pain is usually centered in or around one of the eyes. And the telltale sign for this is that there's associated autonomic symptoms like tearing or nasal congestion, or even some redness of the eye, which makes you think a little bit of maybe you need to worry about an eye issue causing the pain. And then some of these patients can have ptosis, which we really have to kind of put together, make sure that's not something that's ever happened before. If they always get their cluster headaches and get some ptosis, you can feel a little more reassured. But technically, it's a neurodeficit, and it can actually occur with aneurysm that's not ruptured or that has ruptured. So you got to be a little bit careful about that. But if they've had it repeatedly before, it's reasonable to attribute it to that and proceed with treatment.
Realistically, I think I've only seen maybe 2 or 3 cluster headaches in the emergency room, never in urgent care. It's something you always read about in the textbooks and they teach you about in school, but as a thing, because it's so unique, I guess. But in reality, I haven't seen too many of those.
It's pretty uncomfortable condition. Yeah.
All right, so let's mention the clinical decision tools again. SNOOP 10, SNNOOP 10. So there's 10 criteria for this list. And basically, it's a little chart and you figure it out if they have any of these horrible symptoms that they're at risk for a more severe type of headache other than a simple migraine or simple tension headache. They make it more likely. There's things like fever, history of cancer, age, pregnancy. So we didn't really mention that, but you got to think about headache in pregnancy as being eclampsia or preeclampsia. They were published in the Neurology Journal in 2019. You can look it up if you want to. It's probably an MD Calc if you want to look that up. But if they have any of those, it might make you want to think that we need some work up here before we start treating this migraine headache. The autonomous subarachnoid rules, yeah, those are pretty good too. And again, same thing. If you have the headache has to reach peak intensity within an hour, and if they have any of the following, they're at high risk and need to be evaluated. And the funny thing is, I think a lot of people have this stuff, and it's probably pretty sensitive. It doesn't miss anybody that has something bad, but it's probably not very specific. So it would be age greater than 40, neck pain or stiffness, any loss of consciousness at any point, pain occurring with exertion, a thunderclap sensation of the headache, limited neck flexion, and with any of those, you can't rule out subarachnoid. You need to send them in for further evaluation. Just a word about clinical decision tools, and we've mentioned this before. If you use them, you got to know how to use them properly, and you probably should document in the medical record that part of your medical decision making was using this tool, and that's how you derived that if you want to. Just make sure that you really know how to use the tool, because if it is documented in there and you used it wrong, that could come back to bite you in the future.
Sure. So do you want to talk about treatment?
Yes, let's do.
Once we move past diagnosis, that's how we can help the patient. We didn't really talk about pathophysiology, right? But the key to most migraines is felt to be some kind of a dopaminergic pathway. So opposing that is usually going to be your first line treatment. And the American Headache Society recommends first line treatment with prochlorperazine or metoclopramide. Most of the studies study IV use of these, which is not super common in urgent care, although some places do. I think it's still pertinent for us because sometimes patients are so nauseated that we can administer these medications IM. And I'll just tell you anecdotally, it seems like it works. And we're getting the medication into the patient when they can't take orals. I think that's how urgent care can help. So triptans, many patients have these already, and they come to us after they didn't work or maybe have rebound headache after one. But occasionally you get a patient who ran out, and we might be able to administer that, their usual, or give it to them sub-Q, and they might take it some other way, nasally or orally, or they might never have tried it before. And so if you're close to the headache onset, it's reasonable to do. The longer since the onset of the headache you administer it, the more likely they are to get rebound. And you might get faked out by that. They'll leave the clinic feeling well and then get that rebound headache afterwards. So it's important to keep in mind. Ketorolac, this is God's gift to urgent care and ER clinicians, right? Studies actually show that it's better than placebo and better than a combination of sumatriptan and dexamethasone and better than valproic acid, which kind of was up and coming about 20 years ago, but you had to give it quick IV and was mostly an ER thing. I actually never had good results with that. But in terms of comparing it to ketorolac, ketorolac's better. And better, it means better in terms of pain improvement or complete relief. And that's when you ask patients, soon after their treatment or up to 24 hours afterwards, and less frequently getting rebound headaches. I just have to be mindful about contraindications. Ketorolac's pretty strong NSAID. So pregnant patients, you shouldn't give it. Elderly patients on blood thinning medicines and patients with renal issues, even if they're not elderly. Also keep in mind side effects and contraindications with any of these. The medicines that we use for migraine can sometimes have extrapyramidal symptoms. The interesting thing is a lot of times I will usually give it with a little bit of diphenhydramine, even though the issue brings up, and we've kind of known for a long time that giving them together doesn't necessarily decrease the chance of those side effects. Honestly, they say you'd be better off waiting and only administering it to the patients who have those side effects. But I've used both of them in combination pretty luckily and not really had problems. So I still kind of believe in that, even though the studies might show otherwise. There's some new ideas about pathophysiology specifically for migraines. There's these serotonin 5-HT1F agonists. This is Revwow or lasmiditan. And actually, if you look at the structure of these things, we have our triptans. These are actually ditans. So it's a little bit of a simpler molecule, but does similar things. There's actually several new medicines on the market. My wife sometimes gets migraines, and every so often her neurologist will give her something new to try. So it's obviously an area of research and new things, not necessarily that when you use in urgent care, but preventive medicines or abortive medicines that patients can use at home. For cluster headaches, I love this. And I've actually had this work sometimes, just high flow oxygen, get a mask on them and get this high flow, 100% is kind of going to be impossible, but high flow oxygen. And for tension headaches, you're pretty much just trying to break the headache with some kind of analgesia stronger than what they've had. I usually will tend to use ketorolac for those patients, although there's good evidence that using something like prochlorperazine or metoclopramide, maybe with a little bit of ketorolac, works for any kind of headache, which I thought was kind of interesting. You can kind of boil it down to the pathophysiology, but in the end, sometimes you can treat a lot of those primary headaches similarly, and those will actually help with cluster headache also. There's some procedural interventions for headache, the greater occipital nerve block, and then even the sphenopalatine nerve block that can be done. They talk about doing it by squirting some bupivacaine in the nose on both sides. But I was talking to Jonathan Halpert at the convention, and he talked about a couple of migraine patients coming in, and he actually puts 4% lidocaine on a cotton tip applicator and goes in like he's going to do a COVID swab. And when they're kind of uncomfortable, you would just pull back a little bit and you keep it in there for about 5 or 10 minutes. He actually does both sides at the same time. It has good results with that.
It's funny that you say that because I actually do that. And I get tremendous relief with occipital nerve blocks and with the sphenopalatines. I don't know
Yeah.
what happens to them after they leave or if they ever have a rebound or if it comes back, but it seems to work well in the clinic. I used to work in an urgent care that partnered with a neurologist, and we actually had a migraine clinic where we had this little room that they put one of those recliner chairs in with some mood lighting and some muted lights and bottled water and some nature sounds.
Wow.
Yeah. So if he would refer one of his patients for migraine treatment, and we had a whole protocol that we'd use, and the valproate was on that too. And yeah, that didn't work. But, some of the tools in our basket were being able to do those, and we did the sphenopalatine blocks with the cotton swabs. And it actually worked pretty good. And once the patients got over, I mean, because there wasn't nasal swabbing back then, so people weren't used to having
You used to, yeah.
in their noses, but now they're much more useful for that. Yeah, the other thing I really love is the metoclopramide. I experienced that when I was working in the ED and we started using the IV DHE. You would give the metoclopramide first because the DHE causes a fair amount of nausea and vomiting, and that, for whatever reason, that was the protocol, was to give the metoclopramide first. And a lot of times in between giving them metoclopramide and then going back for the DHE, the patient's headaches would be gone. And you're like, okay, I don't have to give the DHE. This is great. Yeah, all set. And actually, not to share personal information, but that's what works for my migraines. I don't get them very much anymore, thank God. But when I did, it was naproxen and metoclopramide was the key to relieving my migraine headache.
Could you take it orally? Did it work if you took it orally? Yeah, that's sweet. I mean, it kind of should. Yeah.
The one thing we didn't mention is steroids. So this was a couple good studies that were actually highlighted in the issue, but steroids are actually really good for breaking the rebound effect. So, you send somebody out the door and probably, I guess about 40%, 50% of them will have some sort of a rebound headache and they're back to square one after they leave. Maybe not quite so bad. And they may have a post-drome that may take a few days for it to go away. And if you give the patient steroids when they're in the clinic, you can reduce the risk of that happening. The studies were all done with dexamethasone IV. We can certainly extrapolate that it will be okay to give it IM, and actually I give it PO because the bioavailability is pretty much the same, and in the onset of action is pretty much the same. So why bother giving it parenterally when you can give it PO? But their studies were with a single dose of dexamethasone, 10 milligrams, which significantly reduces the rate of rebound and reduces the post-drome. No other treatments required. You don't have to send them out with a Medrol dose pack or tapering or prednisone or anything. It's just that one dose of the Decadron is good to go. But again, as with any medication, make sure you rule out those contraindications before you provide it. You don't want to give it to somebody that's had issues with steroids before, somebody whose blood sugar is going to go through the roof or something like that. We've been trying to be very steward-like about our steroid use, but this is one instance where it's actually been proven to have some benefit, and a single dose is probably not going to have too many long-term complications with it.
Yep. The issue talks about medication overuse syndromes, medication overuse headache, MOH, and this can develop in any of the headache disorders, and it comes from them taking medications on a regular basis. And the threshold for making this diagnosis, and it's not hard and fast, but basically if somebody's taking some type of headache treatment more than 2 days per week for more than 2 months, then they fall into this category. And what you see is just basically decreased effectiveness of the headache and sometimes a constant headache. People can be taking medication several times a day in the worst cases of this. And this is whether it's an NSAID, an over-the-counter medication, a prescription medicine, or a triptan or whatever, any headache abortive therapy that's being taken this frequently, you're decreasing its effectiveness, then falls into this category. Treatment really involves stopping the medications. So when they're no longer helping, you just have to stop them. And then initiating some type of preventive therapy. So not a different abortive therapy, but initiating preventive therapy may help. The issue describes a randomized controlled trial with 120 patients that compared patients who they just stopped cold turkey, or they stopped cold turkey and started a preventive medicine, or they kept them on their medication and started the preventive medicine, and I guess assumedly stopped the medicine, their abortive medicine later. And they all did pretty much the same. Although in terms of statistical significance, the combination of stopping the medication and starting preventative one seemed a little bit better just in terms of gross numbers. The medications that they used in that study included amitriptyline and metoprolol, ones that we're fairly familiar with in terms of preventive therapy, but also candesartan and ARB, which I thought was interesting. I didn't know that you could use those. And each one of those had equally good results in all of those treatment arms. So kind of cool.
Yeah. It's funny that you mentioned the medication overuse, because remember at the beginning of this episode, I told you that I had 3 patients this week that said worst headache of my life.
Yeah.
First 2 really weren't. They were just ran out of their meds forever. The third one, she was medication overusing butalbital. And
Oh,
yeah, she had been taking 4 to 5 pills of that a week, 4 headache days per week, and had been on it for about a year and a half. And she insisted that's what her neurologist had prescribed for her. And I'm like, really? I don't think so.
yeah.
I don't think there's too many neurologists that are still using the butalbital combination with the acetaminophen and the caffeine. You know, the episode didn't really talk about caffeine a lot, but anybody that's ever had a migraine will tell you that you take a cup of coffee and sometimes you can make it go away. So I don't know if there's any studies on that, but caffeine is sometimes a useful thing. Opioids. You and I both did ED back in the day when that was all we had. And you had these people coming in day after day for their 4 to 5, 6 milligrams of Dilaudid. They're all like, no more opioids. Just say no. You're going to create a drug seeker when you do that for sure.
Yep.
Actually, studies about this, it doesn't work any better than any of these other drugs that we've just been talking about. And there's a lot of side effects, the sedation effect, the nausea vomiting effect, the addiction effect. And don't forget those return visits, because they're going to feel really good when you gave them the narcotics, and they're going to want that feeling again. So they will probably make you come back for it.
Yeah.
And like I said, they don't work as well as the other options. And the only people you should really be using the opioids in are people that have absolutely no other option for their headache. There's some reason why they can't take the NSAIDs. They're allergic to every triptan. And if they tell you all of those things, you probably should be a little wary about that. So just say no on the opioids. We actually have a sign in our clinic that says we will not dispense opioids from this office. So I could just point at the sign and say, see, I can't give these to you. The truth of the matter is I really can if I want to, but we have that sign there to kind of help us out on the case that we need to say no. And like I said, the butalbital, that's been kind of debunked that does anything for headache. I think it's more the acetaminophen and the caffeine that probably helps the headache rather than the butalbital does. That's actually a barbiturate. It's not an actual opioid, but it still has the same risks for abuse and risks, tolerates, and all that stuff. So if somebody comes in asking for it, try to say no, or just give a couple days supply and say you really should have your primary care doctor get you off of this stuff because it's not doing you any favors. All right, so we treated the headache. What about preventing the headache? Should we be doing that in urgent care?
Yeah, well, we talked a little bit about that for medication overuse headache, but you can actually consider it in somebody who's getting migraines very frequently, but not necessarily that 2 times per week for 2 months. This is something that we can do in urgent care. Options include starting them on propranolol, metoprolol, valproate, Topamax or topiramate, or amitriptyline. Some of those were mentioned in that randomized controlled study. There's dosage ranges for this, and you have to be careful. Some of the migraine sufferers are young women, and their blood pressures might be low to start, so you might not want to use propranolol or metoprolol. And all of them have side effects, and it's important to talk to patients about that. But as you're beginning to have that patient improve with other treatment that you're giving them, and it's the second or third time they've been there in the past few weeks, you can start to think about maybe talking to the patient about this and then referring to their primary care doctor after you start one of these treatments.
Yep.
How about closing thoughts?
I have a few. I think we don't really do right by patients all that well in migraine. I think with a little education, we could probably do better by them. A lot of the places that I've worked in the past, it's, Ketorolac and goodbye. But there's no reason why we can't treat the nausea and vomiting a little bit better. There's no reason why we can't use either metoclopramide or prochlorperazine a little bit. Traditionally treating for nausea and vomiting, but actually has been proven to be effective for headache. So that's something we can do. I know nobody wants to sit and watch a patient for an hour to see if they get better, but I think it's good medicine to keep them out of the ER and to keep them satisfied and happy, and give that good Yelp review of last time I went there, they sent me to the ED, but this time they treated me and I feel so much better. And then just some patient education. Ask them some questions. What's your current migraine treatment now? What does your doctor have you on? And if it's something that you feel isn't the best that it can be, maybe recommend something different for the patient, or maybe recommend that they go back to their primary or their neurologist. Or if they haven't been to the neurologist in a while, maybe suggest it's time to go back. If their current regimen isn't working for them anymore, it might be time for a change. Don't necessarily want to do that in urgent care, but you can certainly go over their meds and recommend some ideas for them. And even if you just suggest they go back and revisit treatment, there's so many new things now. And I've seen a lot of people that come in, they're still on old treatments. It's like, you see the ads on TV, go talk to your doctor about this stuff. There's a lot of stuff out there that might be more helpful for you.
Yeah. So very early on, I remember treating a couple patients with migraine and having them come back like a couple hours later saying, hey, my headache's back. So ever since then, I'll usually talk to patients about the possibility of a rebound headache and talk to them about managing it. They can always come back, but tell them take some naproxen or do another dose of sumatriptan, either individually or in combination. And then that does a couple of things. It'll kind of help with that headache and just kind of move them a little bit farther along. Sometimes that headache cycle, I would have to say most migraine patients are not down to 0 out of 10 at the time. You're sort of moving in the right direction. And what you want to do when people rebound is move them back in the right direction by reinstituting some sort of a treatment. So I'll usually talk to patients about what to do. It's usually pretty simple, something like some naproxen and rest and turn off the lights and that kind of thing. And then you had sort of mentioned this, we tend to think of these as relatively easy, straightforward patients. If they're already diagnosed, you get them their treatment. You might even ask them what they like and make them happy by giving them that. I even find myself doing this. This is somebody that I don't have to think about that much. They got a migraine. They've had migraines before. They like ketorolac and metoclopramide. So go ahead and do that. And it's kind of a slam dunk thing. But we really should think of each patient individually. That will let us peel back those layers and find those patients who maybe have medication overuse headache when you talk to them a little bit more, or think about recommending a preventative medicine to that regular visitor, your regular slam dunk who's there for the third time in 6 weeks. Maybe talk about preventive therapy for them. It's think about your acute issue, but then also think about the other things that can add up to good patient care for any individual patient.
Yeah, absolutely. I usually tell people today's a wash. There's your work note. Go home. I'm giving you a prescription in case you have some issues and the pain comes back. Plan to be a vegetable the rest of the day. Take a no snap. Don't do anything strenuous that's mentally strenuous, and just right off today and start fresh tomorrow, because that also helps preventing rebound or getting rid of that lost bit of the headache that they still have when they walk out your door.
I think so too.
Yep.
I think that, and after an LP, they say lay in bed for 30 minutes and then you can get up and do anything you want. I don't think so.
Definitely a bad idea. Anybody who's ever had one will tell you that's a bad idea. Yeah. All right. So next month we're going back to orthopedics. Yeah, I kind of like ortho.
Cool.
It's fun. And we're actually talking about wrist injuries next month. So look forward to that. We'll talk about all the different types of wrist injuries. And we hope you like the new format. I hope it was a little more interesting. And we hope to see you next month.
Sounds good. Take care, everyone.
All right. Bye-bye. I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to this site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.